So in this section we are going to deal about the investigations that usually done to find out the causes of infertility. In this we are seeing the objectives of investigations. The first is detect the etiology to find out the cause behind the infertility. Second, rectify the abnormality and improve the fertility. Once we are able to know the cause about the infertility, definitely we can use different treatment modalities which are available now to improve the fertility rate of the couple. The last one, give assurance and explanation. As you know, the infertile couple, they may be psychologically very absent. It can be due to the family problems, maybe societal problems. So it is the responsibility of the health person to give maximum assurance, explain about the treatment modalities available so that they will get the proper knowledge. So first we are seeing the case of males. In males, the first is the history taking. Under the history taking, we will see the age of the men that we have already discussed in combined factors, that if the age is above 35 years, it can affect the fertility of the person. Second, the duration of marriage. We need to ask the person how long they have get married. Then the general medical health should be evaluated. We should see whether the person having any underlying issues like any diabetes, hypertension, whether he is taking any beta blockers, any antidepressants. If these drugs are taken, it can affect the fertility rate. So one should find out these all things while taking the history. Okay. Next, reference of the sexually transmitted disease like mumps, orchitis, diabetes, and bronchiectasis. In the defective spermatogenesis, we have seen that if the person had mumps or orchitis or bronchiectasis, this can permanently damage the sperm development. So you need to ask these things. Then inquiry about the relevant surgery, whether the person has undergone any testicular surgery. Okay. Last, ask about the sexual history of the person. We should find out whether the person has frequent intercourse, whether they are doing it at the right time, whether they have proper knowledge about the sex. These all things we need to take while taking the history. After taking the proper history, the next step is the examination of the genital organs. So first, we need to inspect and palpate the genitalia to see is there any tumors present, is there any anatomical problem is there. Second one, see the size and consistency of the testis, whether it is descended or undescended. Next, testicular volume. It must be at least 20 ml. The total volume of the testis should be at least 20 ml. Then the presence of varicocele should be found out, because if the person had varicocele, the total temperature should be above the body temperature. So it can affect the spermatogenesis. So these all things you should analyze while doing the testicular examination. In this slide, we are seeing the investigation that is done in the routine basis. First one is routine examination. Under that, the urine as well as the blood examination is performed. And the second one, and the most important, is the semen analysis. It is collected by the masturbation, and the sample is collected in a clean, dry glass jar and sent to the lab as early as possible. The examination can be performed within 2 hours, but it is the responsibility of the health person to inform the couple that coitus should be avoided 2 to 3 days prior to the test, so that the enough sample can be collected through the masturbation. This we are seeing the Induct evaluation, which is mainly needed for the person who having the problems like azoospermia, which is absence of sperm. You can see in the picture, which is the normal one, and this azoospermia, there is total absence of sperm. Then oligospermia, decreased number of sperm count. Then low volume ejaculate, the ejaculated semen that is ejaculated is very less in volume. Next is the person having problems of sexual potency. So in these cases, we need to do the in-depth evaluation. So next we are going to see the different tests we are doing under the in-depth evaluation to find out the cause of infertility. The first one is serum, FSH, LH, testosterone, prolactin, and TH. While we are discussing the causes of infertility, we have seen that these all hormones are very necessary for the spermatogenesis. So we are assessing whether these hormones are enough in number. So testicular dysfunction causes a rise in FSH and LH. If the testicular function is not going proper, there can be a rise in the FSH and LH. Low FSH and LH suggests hypogonadotrophic and hypogonadism. So if there is any deviation in this hormone level, definitely we can imagine there is something happening in this genital. Something abnormal can be happen in the testicular function. Next is the fructose content in the seminal fluid. The fructose is very necessary in the seminal fluid. If there is an absence of fructose content in the seminal fluid, it suggests that the congenital absence of seminal vesicle. Okay. The last is the testicular biopsy, which we are in this picture. I have shown the testicular biopsy, how they are performing that. So it is mainly done to differentiate the primary testicular failure from any kind of obstruction. Next is the transrectal ultrasound. So it is done to visualize the seminal vesicles. In this picture I have shown that how the probe is introduced. So it has to visualize the seminal vesicles. As you know, the seminal vesicles are a pair of two coiled tubular glands which are lying behind the urinary bladder in males. So they secrete the fluid that partially composes the semen. So by doing this ultrasonography, we can visualize the prostate. If there is any duct obstruction is there, these all things we can find out by doing the transrectal ultrasonography. These are mainly done in the persons who are having the problem of azoospermia, then abnormal vaginal rectal examination, then some duct abnormality in case of ejaculations, and from any kind of genital abnormality. In these cases, we usually perform the transrectal ultrasonography. Next is the vasogram, that is a one radiographic study. The picture I have given here. It is done to evaluate the ejaculatory duct obstruction. These all things are mainly done to find out if there is an obstruction in the duct, so that it can affect the transportation of the sperm. There are some more tests that we usually perform. The first one is karyotype analysis. It is also known as chromosome analysis, and this is mainly done to reveal certain genetic abnormalities, especially when the FHS is raised. This karyotype analysis is done, and the person who are azoospermia, who having no sperm in the semen, in these cases the karyotype analysis is done. Next one is the immunological test. In that there are two antibodies that are sperm agglutinating and sperm immobilizing. These antibodies can be produced following some infections which can cause the infertility. So the antibodies can be detected from the serum. So this is immunological test. Next is the presence of plenty of sperm cells. So the collected fluid is examined, it is strained and cultured to detect any organism like gonococcal infections or any bacterial infections are present which can lead to infertility. So these are some types of in-depth evaluation that we will perform. Till now we have discussed what all the investigations that we used to perform in the males. Now we are going to see what are things that we are doing in the female. So same as in male, the first step is taking the history. Under history, the first is age, that the age should not be more than 35 years. Next, the duration of marriage, the total years that they have get married. Then the history of previous marriage with proven fertility, whether she had any previous marriage with the children in that marriage. These all things we need to ask in history. The second one is general medical history. Under that, you need to see whether the female person have any tuberculosis infection in the history, whether she had any sexually transmitted disease, features suggestive of any pelvic inflammatory disease or DM or hypertension, whether she is taking any tablets for these diseases. These all things we need to take under the medical history. Next one, the surgical history. In surgical history, especially we need to ask over the surgeries, whether she had performed in the abdomen or any pelvic surgery she had undergone. Next, the menstrual history. In that, the abnormalities related to oligomenorrhea or amenorrhea. We need to see whether she has an oligomenorrhea or does she have the proper menstruation in every month. What is the time period of menstruation, whether it is 5 bar 28 or 4 bar 28. Does she have any dysmenorrhea during that period? These all things we need to ask in the menstrual history. Lastly, the previous obstetric history, in that including the number of pregnancies, how many times she does conceive, interval between each pregnancies, the gap between each pregnancies, and does she had any pregnancy related complications during the pregnancy as well as during the delivery time. These all things we should have a correct knowledge from the person. There are some more things that we need to ask in the history, that is the contraceptive practices, whether she had taken any drugs, whether she used any protective devices like IUD, then any sexual problems like dysmenorrhea, does she have pain during the intercourse, or loss of libido, that means she doesn't have any pleasure while during the sex. These all things we need to ask while taking the history. So after taking the history examination, the next step is the examination. So under that, the first is the general examination. Special emphasis on the obesity. Nowadays, you can see that the obesity is the main factor that hinders the fertility rate in the woman. So there should be a marked reduction in the obesity, or the BMI should be come under the normal, that is 20 to 25. Then check for the hirsutism, so that I have given one picture. You can see here the overgrowth of hair on the face. Then acne or underdeveloped secondary sex characters should be noted while doing the general examination. Next is the systemic examination. Under that, the health person should detect the abnormalities like hypertension, organic heart disease, any heart disease, chronic renal lesions, or the person having any thyroid dysfunction, whether she is taking any tablet for the thyroid problem. In this, we are seeing the gynecological examination. The first one, it includes the adequacy of the hymenal opening. So, doctor should see the hymen, whether it is rigid or whether the opening is adequate. In some cases, the doctor needs to do the hymenectomy so that there will be adequate opening. Second, any evidence of vaginal infections like any pelvic infections or any cervical tear, or sometimes any kind of chronic infections. At the same time, she should assess for undue elongation of the cervix. If the cervix length is, there is congenital elongation of cervix, it can affect the transportation of the sperm towards the uterus. So that she should assess. Next, the uterine size and the position. As you know, the normal position of the uterus is antiflush and antiwater, whether it is in the correct position. So these all things she should assess during the gynecological examination. Next is the speculum examination, which reveals about the abnormal cervical discharge. So the speculum examination, even if it is SIMS or Cuscus speculum examination, it helps the doctor to have a good idea about the cervix, whether it is normal, whether any cervical discharge is present, any blood stream is present. These all things can be revealed with the help of speculum examination. So from this slide, we are seeing the diagnosis of ovulation. It is mainly two types, that is indirect and direct one. First, we are seeing the indirect. Under that, the first one is menstrual history. Check the evidences of ovulations like regular normal menstruation, loss. We need to ask whether she have normal menstruation at every month. What is the total days that she having the menstruation? What is the amount of blood loss she has? These things you need to ask. Then mid-menstrual bleeding, after the menstruation, whether she have any spotting, that also you need to ask. Then premenstrual syndrome or any primary dysmenorrhea, before starting the menstruation itself, whether she have any abdominal pain, any leg cramps. These things you need to assess in the menstrual history. Next, we are seeing the basal body temperature. So it is the evaluation of peripheral changes which helps to know about when the ovulation exactly is happening. So here the rise of temperature is secondary to the rise in progesterone, and the progesterone is a thermogenic hormone. So if you're maintaining a chart, you can see there is a rise in the temperature, and it can be happened just during the ovulation due to the progesterone release. This progesterone is released by the corpus luteum after the ovulation. So this progesterone can increase the temperature. If you are maintaining a chart, I have made one chart here. You can see that this will just rise in the temperature during the 15 to 17 days. So the ovulation can be happen between these times. Okay, so it is a procedure. In this procedure, we will instruct the mother to take the oral temperature daily on waking in the morning before rising from the bed. The wife need to take the oral temperature. She need to note it on the chart just below the day. Then days when intercourse should take place should also noted. When they are doing the sex also should be noted in the chart. So what are the interpretations that we can make once we have made the chart based on the temperature? The temperature maintained toward the first half of the cycle. If you had seen the chart, you might have seen that in the first half, that is about first to 15 days, the temperature has maintained, and it raised to about 0.5 to 1 degree following the ovulation. Just after the ovulation, it raised to 1.5 to 1 degree, and the rise sustains towards the second half of the cycle. About 17 to 28 days, the rise was in a stable period. It sustains during the second half of the cycle, but it falls about 2 days prior to the next period. Before the next period, 2 days before the next period, it just comes down. This is known as a biphasic pattern. There may be a drop in the temperature to about 0.5 degree before the next rise. So these are the interpretations that we can make if you are maintaining a chart. So here we are seeing the vaginal cytology. So in this vagina, discharge is taken through smear test during the 25th or 26th day of the cycle, and it reveals the features of progesterone effect if the ovulation happens. So if the person is not ovulating, the progesterone effect will not be seen in the smear. Next is the hormone estimation, in that the post is serum progesterone. It is done on the day 8th and 21st of the cycle, and if there is an increase greater than 6 nanograms per ml, it suggests the ovulation. So usually the progesterone will be increased more after the ovulation, which is produced by the corpus luteum. So if there is an increased level more than 6 nanograms, it suggests the ovulation. Next is the serum luteinizing hormone, that is serum LH. So if your daily estimation of serum LH, if you are doing the estimation of serum LH at the mid-cycle, can detect the LH site in between, that is closely towards the 14th day, there will be a surge of the luteinizing hormone, and the ovulation occurs about 34 to 36 hours beginning of the LH surge. So ovulation can occur after the beginning of LH surge, that is just after 34 to 36 hours this ovulation can happen, or it can coincide. Once the LH comes at the peak level, the ovulation can just happen between the 10 to 12 hours. And next is the serum estradiol level. So it attains the peak rise approximately 24 hours prior to the luteinizing hormone surge. That means about 24 to 36 hours prior to the ovulation, the serum estradiol level will get increased. Okay. Next is the urinary luteinizing hormone. Now you can see in the picture, these are the kits available so that you can access the luteinizing hormone in the urine level. So I have already explained that the luteinizing hormone gets its maximum during the mid-period, that is the days that are close to 14 or 16. So once the luteinizing hormone reach its peak level, you can decide that the ovulation will happen within 2 days or within 3 days after this luteinizing surge. So if you are analyzing using this urinary kit, you can know when this ovulation will usually happen. Next is the endometrial biopsy. So this is a type of biopsy in which the endometrial tissues are taken to detect the ovulation. So Here we are using one catheter or pipette is used to take the endometrial sample, and it is done during the 21st to 23rd day of the cycle. In the picture you can see one catheter is inserted to the vagina and it reaches the uterus. From there the endometrial sample is taken through the catheter itself. Okay, the next one is sonography. So in this, the transvaginal sonography is mainly performed to measure the Graafian follicle just prior to the ovulation. So usually the diameter of the Graafian follicle is 18 to 20 mm in diameter, closely to the ovulation. And the features of recent ovulations are, if the ovulation has already occurred, you can see the collapsed Graafian follicle as well as fluid in the pouch of Douglas. Till now we have discussed the examination through the indirect method. Next we are going to see the direct method. In that the first one is laparoscopy, which is very familiar to you all. So it gives the direct evidence of the ovulation. You can see how the laparoscopy surgery is performed. So you can know about we can see the reason corpus luteum is the ovulation occurred. You can see the corpus luteum in the ovary and the presence of ovum from the aspirated peritoneal fluid from the pouch of Douglas. If the ovulation had already happened, you can see the ovum from the peritoneal fluid which is filled in the pouch of Douglas. So through the laparoscopy you will get a clear-cut picture about the ovulation. In this slide, we are seeing the tubal factors, that how we can diagnose in tubal factors. So the test we are using is insufflation test. So the principal cervical canal is continued with the peritoneal cavity through the tubes. As you know that the down portion, the below portion cervix, then the uterus. The uterus is connected with the fallopian tubes on both sides, and the fallopian tube opens in the peritoneal cavity. So if the air or carbon dioxide is entered into the peritoneal cavity when pushed through a transcervical, it gives the evidence of patent fallopian tube. So this is the procedure mainly done in the insufflation test. So it is mainly done 2 days after the menstruation stops, and it is contraindicated if the mother having any kind of infection. Mainly this test is done to see whether the tube is patent or not. Next test is the hysteroscopy. The principle is same as in the insufflation test, but instead of air, here the dye is used and radiographic assessment is done. The main advantage is that as the dye is pushed to the transcervically, you can clearly see whether the tube is patent or which tube is blocked and the side which is blocked. And even if there is any uterine abnormality also we can detect through this method. But the only disadvantage is the radiation risk. The third method is the laparoscopy, which is considered as the golden standard for evaluating the tubal factors. Through the laparoscopy, you can clearly visualize whether the fallopian tube is blocked or whether it is patent. Okay, the fourth one is sonohysteroscopy. Here, the normal saline or the saline is pushed within the uterine cavity using a Foley's catheter. In the picture, you can see we are inserting a Foley's catheter and pushing the normal saline towards the uterus. And after that, the catheter balloon is inflated at the level of cervix. The balloon will be inflated at the level of cervix so that it prevents the fluid leakage from the uterus. Then the USG of the fallopian tubes are taken to see whether it is patent or if there any stricture is present. And the main advantage is that it is a non-invasive procedure. No dye we are using, so there is no radiation risk. And even you can detect the uterine malformation too, if there any congenital malformation is present. So this is another test which are used to find out any tubal factor. The fifth method is falloposcopy. So in this study, the entire length of the fallopian tube. The entire length of the fallopian tube is examined through the falloposcopy. Here a fine, flexible fiber optic device is used that you can see in the diagram that is given here. fine flexible device is inserted through the uterus till it reaches the end of the fallopian tube, and it has to see the tubulostia, any mucosal changes is there, any polyp is present. These all things we can see through this technique. Okay, the next one is salpingoscopy. So it has to access the tubal lumen with the help of introducing a rigid endoscope to the fibrial end of the tube. Here, as you can see, the side of the fallopian tube is fibria, through which the endoscope is introduced and will assess if there is any lumen abnormalities are present in the fallopian tube. Till now we have discussed about how we can diagnose the tubal factors. In this slide we are seeing the uterine factors which are commonly associated with infertility. They are usually fibroids, congenital malformation of uterus and intrauterine adhesions. These all things we can diagnose with the help of ultrasonography, hysteroscopy and laparoscopy for the in-depth evaluation. Last, we are seeing the cervical factors which affect the infertility. So, normally during the proliferative phase, the cervical discharge allows the sperm to move towards the uterus, and in the secretory phase, it hinders the entry of the sperm. So, the main thing is to identify the cervical discharge during the ovulation phase. We need to identify whether the cervix allowing the sperm to reach the uterus. There are somewhat tests for that. The first one is post-coital test. In that, we are assessing the quality of cervical mucosa. We are taking the mucosa of the cervix and we will assess whether the sperm is able to overcome this mucosa and reach the uterus. Next one is the sperm cervical mucus contact test. In this, we are doing in the lab setting. The cervical mucosa of the wife during the mid-cycle is collected, as well as the semen of the husband is taken, and we are seeing whether the sperm can cross the mucosal level and reach the uterus. So these are the main two tests that we are doing to assess if there are any cervical factors that affect the movement of the sperm towards the uterus. So in this section, we were discussing about the main investigations that we are performing in males as well as in females to assess the infertility. I hope you all are clear about this topic. Thank you for listening. Thank you for watching. Please subscribe my channel to view the new videos related to BSc Nursing, and don't forget to press the bell icon to get further notifications.